Hello and welcome to #OurDocTalk. This is NorthBay Healthcare's way to answer questions on important health issues. With us today is Dr. Seth Kaufman. He's the Chief Medical Officer at NorthBay Healthcare. He's also an emergency medicine physician. And so we're going to be talking about COVID testing today.
Good morning, everybody. Thanks for joining us. So the topic for today is testing. Of course, I'm always happy to answer any of your questions, but we're going to focus on testing today. But I want to start off, as I have for other talks, with some of the numbers, and then we'll go into testing and what those numbers really mean. So I'm going to turn over to my computer here and give you some of our county numbers. And as I've said in previous talks, these numbers are available on the county website. As of yesterday at 4:30, it's updated daily at 4:30, there was 502 confirmed cases, 75 total hospitalizations in our county, and 21 deaths. That is a significant increase over the weekend and into this week, and we are concerned about that. So that's, if you can look at the website, you can see the trend upwards. No one should think in our county, or really in our country, that we are beating this yet. So I'm just telling you, the numbers continue to increase. In many areas, it's plateauing and flattening, but we remain very concerned. And the key is what we've seen with our cases. And before I go any further, let me tell you our numbers. We've tested a total, between all the different types of tests, we've tested a total of about 2,000 people at NorthBay Healthcare. So that's between our urgent care and our hospital-based patients, and I'm just estimating, but around 2,000. As an example, in our urgent care, we've done very well and have tested 850 people, and we've had 29 total positives. So you can do that math, but essentially, it's a few percentage point positive, essentially three, somewhere around there. And on our hospital-based testing, we've had about a 5% positive rate. So it's been consistent. The concern, by the way, when we look deep into these cases, we continue to see that many are from clusters of cases, not everyone, but many where there could have been maybe an opportunity to avoid the transmission with social distancing, good hand washing, and mask wearing. We don't completely know that. Obviously, it's not every case, but there's no doubt that many of the increases in cases we're seeing in the last week or two is related to clusters, weekend parties and things like that. Things you're reading about, whether it's in South Korea or in parts of our country, where you see clusters of positive cases from social gatherings and things like that. So my message there, of course, is be careful. Continue to practice all those good transmission prevention measures, and we will get through this together. With that, let's talk about testing. What I thought I would do is talk to you about the different types of tests, the availability of those tests, and the limitations of those tests. And I'll spend a few minutes on that, and then happy to start answering questions. So there are a lot of different tests out there. We have never, in my career, which is 20 years or so, I've never been through a time when tests have been fast-tracked from development to use so quickly. And I think that's true for a lot, for any recent memory. I don't think medicine has ever seen tests go through so quickly. We had to do this. The FDA needed to do this. We needed to do this. But keep in mind that all the news stories you read about whether a test has value or doesn't, or works or has false positives or sensitivity, and the negative predictive values and positive predictive values that we're going to get into today a little bit, all that is something that generally is vetted a lot earlier on, and tests don't go to use in such widespread areas so quickly. Usually all those things are worked out, and we know whether the test has value or not, usually for other things much earlier on, and not using it regularly before we really have all the data we need. So in summary, these tests are very imperfect. And I think everybody's doing their best to use them in a way that has value, but just know that every week a new study is coming out and it changes the value of those tests. So let's talk about the PCR diagnostic swabs. These are the tests you can get at Quest. Our Solano County partners run it in their lab. UCSF helps and also runs many of our Solano County tests. We also have a diagnostic swab that's a rapid test, and that's a little bit different type of test. So let's start about these PCR diagnostic swabs. They're the most common way we are diagnosing COVID-19. And I would say that at this stage, we still don't know whether those tests are great, but we do think they're good. Let's talk about what makes a test good or bad. So there's the sensitivity and specificity of a test, and there's the negative predictive value and the positive predictive value of a test. The sensitivity test tells you, if it has high sensitivity, it tells you that if you don't have the disease, that the test will likely be negative. And the specificity of the test tells you that if you're positive, that likely you really have that disease. In other words, if it has good specificity, then you don't have a lot of false positives. When you're positive, you can say, if I'm positive for COVID, it really is probably COVID, and the test is correct. And if you have good sensitivity, then when your doctor tells you, hey, your test came out negative, you can feel really confident, like that really means I don't have it. The problem with the sensitivity and specificity is that it doesn't take into account prevalence. Prevalence meaning how present is that disease in your area. And we don't really know for Solano County. There's some tests out of Santa Clara. They did some testing and it showed it was several percent, which we felt was high. We know New York's kind of high, and again, that sits in the 5-10%, something like that. We don't know in Solano County. We're doing our best to test as many people as possible and get a picture of it. But likely in most areas, the prevalence of the disease is a few percentage points. So a few percent. And when you're at those low numbers, then really when it comes to a positive predictive value, it needs to be very, very high if you're looking for a rare illness. So if you're looking for a rare illness, if the test is not specific enough, then you run the risk of having false positives. So with that, here's the summary on the diagnostic swabs. If you are, the overall feeling of it is that the sensitivity is probably in the 70-80% range, and the specificity is probably very good. But again, with a low prevalence in our county, we feel that we can rely on those diagnostic swabs. But if you have, so we feel we can rely on the diagnostic swabs, and both negative and positive, we do our best looking at the clinical picture. We feel we can rely on those tests. That brings us to the rapid test, which has gotten the Abbott rapid test has gotten a lot of press in the last few weeks. There was a study out of NYU in the last few weeks showing that the sensitivity was even lower. And also the specificity was mixed also. And that has caused a lot of problems. So here's the way to look at it. That means essentially that in communities where you have a high prevalence, likely the rapid test, a negative rapid test, may not be very helpful. In areas where there's a very low prevalence, the test still may have some value. The same goes is that in situations where we really feel like a patient may not have COVID, it doesn't look like COVID, a positive rapid test may not be very helpful. Sometimes it's good to either decide that it's still COVID or to do another test at different kinds of tests. So in summary, we kind of look at each case individually. You look at the clinical picture. Do you have the symptoms, the signs of COVID? And then we rely more on the diagnostic swab than we do on the rapid test. Overall, the positive predictive value and negative predictive value of our Quest and County swab test is better than the rapid test. However, the rapid test comes back very quickly. And in cases where we aren't as concerned that the patient has COVID, sometimes we're doing it as a test before going to surgery. It's somebody with no cough, no shortness of breath, no symptoms. A negative rapid test may still have some value. There are other rapid tests out there. NorthBay Healthcare is looking at them. Other systems are looking at them. They all have different sensitivity and specificities, but those are the big three that we know well and we use here at NorthBay Healthcare. I want to talk about serology testing. That's the other major type of test, and that's the antibody testing. So the most common one is looking at IgG and IgM. Also getting a lot of press. Actually, there was just a recent CDC warning about the reliability of that test, showing that half the time it may not be correct. So here's the scoop on serology testing. It is very hard to interpret serology tests, both the good ones and the ones that we don't feel are very good. Number one, there are a lot out there. I think I said on a previous talk, If one want to have an antibody test, your doctor can order it through Quest. That's what we use here at NorthBay Healthcare, but also the other major commercial laboratory in the country that is LabCorp, and they also have antibody testing available. But just know that it's hard to know what to do with the result, and therefore professional organizations, CDC, and others are not recommending that at this stage that we use antibody testing as a diagnostic tool. It's being used for research. It's being used to maybe look at, like, as an academic exercise to say, hey, what's the possible prevalence in a particular community? But the recommendation right now is not to use it to tell you whether you're immune and to tell you whether you've had it or been exposed. But with that, here's what you should know about antibody testing. IgM and IgG. So IgM is generally present about a week after, maybe a little shorter, maybe a little longer, but somewhere in the first week after you have symptoms, if you mount enough of a response. So that's a type of antibody, you get infected, and your body produces these IgM antibodies. About 2 weeks out, and there was just a recent study showing it's even farther, so 2 weeks plus out, you'll start developing more longer-term antibodies called IgG. Overall, IgM, again, shows up earlier, but is not thought to be as specific. In other words, if you are positive for IgM, it may mean that you had coronavirus, COVID-19, or a different type of coronavirus or something else. IgG is a little more reliable on that, but there's still some concern that if you even had IgG in your body, does that mean you had COVID-19 or one of the numerous other coronaviruses? If your IgM comes out negative, it could, in other words, you don't have it in your body. It could mean that you didn't have COVID-19. It could mean that you didn't mount a response and you have it or had a mild form, but you didn't mount a response. And the same goes with IgG. You may have not mounted enough of an immune response to have the test turn positive. And both tests can be negative if you're too early on. So it has really very little value in somebody who's showing up with 1 or 2 days of a cough and say, hey, I want to be tested with antibodies to see if I have COVID-19. It may be way too early to even know whether to even have a test turn positive. Again, the IgM is earlier and shows up somewhere in the first week, and it takes 2+ weeks or so, somewhere around there, to test positive for IgG. In summary, my recommendation is that if you feel you need an antibody test or want an antibody test, it's a good discussion with your primary care doctor, so that you can interpret the results in the right way. Let's talk about availability of these tests. I'll say that both are available. The diagnostic swabs that I just discussed, the county and the Quest tests, are widely available. There are 2 state-run testing areas in Vacaville and Vallejo, and the county has its own testing site. All that is available on the Solano County Public Health website. So, and anyone can sign up. Our state tests are for patients with symptoms or without symptoms. So it really is available to anyone, and it's free. It's free. Quest has diagnostic swabs also, and NorthBay Urgent Care is doing testing if you have symptoms. While it's widely available, what happens though is it's like everything. Once we fill the machines up to be processed, the time it takes to get the test back goes longer. So while we want people to be tested who have symptoms, we still have to be careful and make sure that we are not clogging up the testing sites so much that it takes a long time for those tests to come back. And we've seen that. When we start sending more tests in to be processed, the time it takes to get the results back, which is really important, is a week or so or longer sometimes. So the answer, so one common question is, should I just get tested? And my recommendation today, and that might change, is that patients with symptoms, especially if you fall into high-risk groups, like you're at risk for getting sick, those with older age, if you're immunocompromised, if you like diabetes or things like that, cardiovascular disease. My recommendation, if you have symptoms, is absolutely to get evaluated and to be tested. For those who don't have symptoms, I think if you feel you want to be tested, just know that the test result may not be reliable for anyone, right? But also, especially for that population. where if the test turned out positive, there's a chance that you never have the disease. You could have a false positive. It just depends on the type of test you do and other factors. Again, the value of having the conversation with your primary care doctor if you want to get tested. I do think as we continue to grow our contact investigations, looking at families and clusters of cases, those with no symptoms, if you had a confirmed exposure, will absolutely there'll be recommendations to get tested. So we should be testing people with symptoms, especially if they fall into high-risk groups. We should be testing those without symptoms if they had confirmed exposures. And of course, I'm a big advocate, and everybody is, about testing those who live in high-impact areas, nursing homes, other like group areas where you're really forced to live in close quarters. We really want those people tested. It's a very common areas. Those are very common areas for outbreaks, and the way to protect them is to test, and of course use good PPE and other prevention measures. So that is what I have in terms of my introductions on testing. I'm happy to answer questions. I'm going to turn to Robin here, who's monitoring our questions.
Sure, we have a couple. Are we seeing an uptick in cases as more testing is done? Is that a result of more testing being done, or are people maybe getting a little more lax?
Very common, super great question. It is a combination of both. In the last week or two, I would tell you that in the last few weeks, I will say that I think the uptick in cases is mostly, not everything, mostly a result of an increase in cases. I would say overall, it's really a mix of both. Absolutely, our ability to test is increasing, but we now have pretty widespread testing of the county and the Quest tests. And I think it's a combination, but most in the last few weeks is clusters and other real cases, and not just because we're testing more.
Are you concerned at all that as we open up, more cases will show up?
Is the question? Are my concerns as we have more widespread testing, will we get more positives? Absolutely. But that's good. Let's see what we have in our community in terms of prevalence. I think the closer we can get to a real prevalence level, the more we'll be able to interpret these tests. And that's probably one of the themes of this talk is, if you want to have a real good picture of whether these tests are great or not, and I get questions constantly about, like, can I trust the test? Can I trust the test? One major step is you need to know the prevalence in your community to really trust a test, because that's how we measure our positive predictive value and our negative predictive value. How predictive is it that the positive test is real? How predictive is it a negative test is real and really reflects those results?
Do you think all essential workers should be tested?
Do I think that all essential workers should be tested? Let's see. No, I don't feel that way right now, and I'll tell you my reasons. I think when it comes to, essential. So let me answer that a few ways. I think essential workers should be constantly self-monitoring for symptoms. It's really, really important. And if you have absolutely any symptoms, from mild symptoms to other, anything, that you should be seeking care and getting tested. So I think we can still continue to follow a symptomatic testing, symptom tracking pathway, and I think that's a safe way to do it. And I'll tell you why. Number one, I think while you're very contagious early on, if we can catch you right when you have symptoms, and essential workers, like everybody, are being really compliant with mask wearing, hand hygiene, social distancing, that the chance of transmission of that to others is low. So that's number one. Number two, you just need to know what to do with the result. They're both false negatives and false positives. So no, I don't think at this stage widespread asymptomatic essential worker testing is necessary. Now with that, it's not like it's harmful usually, right? It's not a surgery. It's not a lot of complications to having a swab in your nose, which we could talk about. The swab in your nose, it's not comfortable.
That's what my next question was going to be.
But I think with that, if we have if we can do it and we get everybody tested, you need to be tested on a regular basis because it's just one point in time. If we're going to have a screening where we're going to screen all essential workers, whether they have symptoms or not, keep in mind that one point in time is just that one point in time. So I'm not against it. I just don't think in terms of resource use and with the availability of testing now that we should be spending our resources on that. We should be spending our resources in high risk areas like nursing homes and other group homes. And then if we continue to have more testing, more resources, I'm fine with us screen. I'm really an advocate for testing, and so is everybody. Like, let's test and see what our real prevalence is. So, but I wouldn't have all essential workers as a top priority. I would have nursing home and other group homes, and make sure that our essential workers are self-monitoring for symptoms, and that our entire county and the whole world is being really good about those prevention transmission measures.
And as far as that swab goes, why does it have to be that big, long swab all the way to the back of your throat?
Yeah.
And how painful is it? Because it looks pretty painful.
It's really uncomfortable. It's very uncomfortable. It is a more, you should know that some of the tests that are out there allow you to do either an anterior nose, so I'm using, let's see, so the front of your nose, or that really far back sample. Over and over again, the data shows that the far back sample is more reliable. And when it comes to having good test results, the most important factor is the quality of the specimen. So if we don't get a good amount of snot on that nose, it's not going to be a reliable result. Many of the tests that are out there do get, many of the results that are tests that are out there do get tested first in the laboratory of these companies. They all do before they're put out to hospitals and clinics to use. And actually, their numbers look very good, but those are artificial environments, and they know that too. They know that those are artificial environments. Once you put it out to hospitals and clinics, the specimen you're collecting in a real nose, not a fake environment, really it is one of the most important factors with the reliability test. So the reality is that you're going through a lot more of an uncomfortable procedure for that far back swab, but know that you can trust your test result more because of that. It's much more reliable. I will tell you, it's a question I saw that, well, then what does it mean for children? And are children's specimens as reliable and that kind of thing? And the reality is I'm not aware of any data that shows that you can't get the same quality sample from a child as you can from an adult. So it's the same. There's no difference, but we are trying, because of that nasal pharyngeal swab request where it's way far back in the nose, we are, when possible, we're trying not to test children because it is fairly uncomfortable. It's an uncomfortable test. And as you know, we don't want our children to be fearful of doctors, fearful of clinics, fearful of the emergency room or urgent care. So we are testing children, but while the adults can tolerate that swab, children will, can't, and we don't want to put them through something that uncomfortable if we don't have to. So we are testing children, but and there's no difference in the quality of the specimen, but we are being a little extra careful in our decision making on that, so we're not putting children through an unnecessary, uncomfortable procedure.
Is there any work being done on a home test, and how soon might we see something like that?
Yeah, I'm not aware of any home swab tests, but the kits that are out there are kits out there that can be done at home. The CDC, I have to admit, and it's a few weeks ago that last time I looked this up, but there wasn't a lot of advocacy for self-swabbing. I think the overall feeling is you won't get the same quality specimen. So I'm not aware of a lot of interest or for self-swabbing, and therefore these swab kits. There are absolutely, you can order a home serology, so antibody tests. They're out there. I'm not aware of tests that are absolutely for homes, and there's really a lot of mixed opinions about self-swabbing, about putting that swab in your nose yourself. So I'm not for it or against it necessarily, but I know the CDC at one point have weighed in about it, but it may be in our future. If you decide to order a home antibody test, just know that also, like all the tests out there, there's a lot. And because of how quickly we had to go from development to commercialization of these tests, some are high quality and some have not been shown to be very high quality. So just be careful. Again, I would recommend talking to your doctor about the best test to order if you're going to order a home test, a home antibody test. And on the swabs, I think it's hard to know.
Does insurance cover all these different types of tests? I know the county tests are free, but if you're ordering one in the hospital through your doctor, is that free? Or
yes, insurance is covering all testing, and it should be free. The insurance companies are across the board doing these tests for free. And those are covered, whether you get reimbursed or not have to pay right at the time of the test. These are covered, correct, with a doctor's order. So that's part of it. There is a Quest direct antibody test, and the 3 platforms they use for the antibody tests are thought to be some of the better ones. If you go to the FDA website and look up the different types of antibody tests and what's been approved through the emergency use of the EUA, they have the 3 that they use are on that list of approved tests. That doesn't mean it was formally FDA approved. It was approved through the EUA, so the emergency approval. Those are on the FDA. The 3 they use are on the FDA website. There is a way to get tested without going to your doctor and getting an order, and those I don't believe would be covered by insurance because they're not through your own doctor. So I'm not 100% on that, but I believe it's on their website. It talks about how you'd be paying cash essentially for that test. If you go through your doctor, right, who are kind of in network with your insurance, it is covered.
So let's talk about what happens if somebody tests positive for COVID-19. Like, then what? Do they end up automatically in the hospital? How do you decide?
There's a lot of that. That's a hard. It depends. It's case by case. So first and foremost, anyone who's test positive or even has a COVID-sounding syndrome, following our Solano public health guidelines, are on isolation for 10 days from symptom onset or the test being positive. So if you're well enough to be at home, you are on isolation, separate from your family, closed space for 10 days. And that has been revised a few times in the last 6 weeks following CDC and CDPH, California Department of Public Health, recommendations, and following more and more data about how infectious you are. We know you're very infectious early on, and then overall the data is showing that you become less and less infectious as the days go on. So that's where that 10 days is from. So what you're doing is you're really protecting your community, your family, and everybody from respecting that isolation order. When you're positive, public health will call you and discuss all this with you. And of course, depending on where you have your test, you will also be called by those clinics and sites, and they'll give you education and talk about what it means. Remember, the vast majority of patients absolutely do fine with this disease. Now, for those that need hospitalization or, God forbid, an intensive care unit admission, it's not for this talk today, but we have treatments that we can use here and there. Obviously, there's more and more data coming out about them. Nobody thinks there's not yet an amazing treatment yet, but remdesivir is showing more and more promise. The criteria we use for admission is we look at a number of factors. And again, remember, in medicine, we look at the whole clinical picture. It's not like one thing alone is an automatic admission most of the time. You look at the whole clinical picture, the person. We have to decide whether we believe in the test or not, that test result. But things like low oxygen levels, really important. Low blood pressure, really important. Are your laboratory, your blood work showing that you have possibly a bloodborne infection? Or this disease, what we're seeing is that people have a robust inflammatory response to the disease. And so if your lab tests show that, that's an admission to the hospital. If your chest x-ray shows a lot of pneumonia, that's an admission to the hospital. So those are some of the things we look at. Low oxygen levels are probably the most important one. So that's the oxygen saturation that we look at, but also looking at chest x-ray findings and signs that your body is inflamed from the infection.
One final question before we wrap up. As businesses reopen, there may be some companies where they can't do the social distancing. I'm thinking like hairdressers. They have to be close to you to cut your hair. They can't be 6 feet apart. So you have recommendations for situations where they can't do all of the required things to stay
Sure.
safe.
You should know that these recommendations don't come from me, although they are many of them are common sense. But if you go to the Solana Public Health website, there are requirements for these businesses that they must follow to open. So it's not so much about recommendations as it is that the opening of more and more businesses they're not just you can't just open. And our business leaders, our small business owners know, of course, they're doing the best they can, following the requirements that you have to open your business safely. And none of it's going to surprise you. Absolutely trying as best as possible to have some level of physical distancing, so that social distancing is the 6 feet away rule or more. But we, there are environments where you just can't do that. You can't cut hair from 6 feet away. So it's physical distancing. Absolutely mandatory mask wearing and hand hygiene, glove wearing, things like that. So I don't have like any magic recommendation here. It's the same thing you've heard of, but the key is that everybody is respecting the prevention transmission. And I would tell you that if you want to see the specifics, it is on the Solana Public Health website talking about how businesses can open in a safe way. And the key, by the way, is physical distancing, hand hygiene, mask wearing, and doing what you can to keep people as separated as possible.
All right. I think we're going to wrap this up for today. Tune in every Thursday at 10 a.m. We're going to do some more of these chats each week. And thank you, Dr. Kaufman, for taking time out of your schedule. We really appreciate it.
Stay safe. Thank you.